Thank you, Chair, for those lavishing introductory remarks. Excellencies, that's what I learned yesterday, that we are all here, Excellencies. Good morning. On behalf of the Malawi delegation, and of course the Secretary for Health for Malawi, who is here, Dr. Charles Mwansambo, I'm going to make the presentation on how the Malawi government looked at systems issues to make sure that the newborn is treated fairly, but also everybody else in the nation. The outline of my presentation, we're going to look at the health demographics of the country before we went into the system-wide changes. We're also going to look at the why or the rationale behind these changes. We also have a chance to look at what were the focus areas that were changed. And then, of course, you cannot make change without having a plan. So we'll look at the Malawi's health strategic plan, and of course, an essential health package where the newborn care is nested in. And then we would look at the specifics on the systems that were changed, and then eventually we'll look at the challenges, achievements, and our way forward. Just to take you through what were the demographics, this is in 2004, before we started the system-wide changes. At that time, our population was 11.8 million, and our maternal mortality was at 984, infant mortality was at 76, neonatal mortality at 36, under 5, mortality at 145, skilled attendance at delivery was at 57, contraceptive prevalence rate was, that's a mistake, should be 28, not 48, and then total fertility rate was 6. To look at issues of systems where we were looking at human resources for health, we had a very high vacancy rate at 65% amongst the key health professionals, with probably a density of 3 per 10,000 population. Health facilities that were able to deliver a comprehensive package of the essential health package for Malawi, only 13% of the facilities were able to do that. And if we looked at the budget to the health sector, only 7% of the government budget was going for health, actually less than 7%. And then looking at our health centers where most of the population get their care, we are able to meet the staffing norms which we had set for ourselves. It was only 10%. So you can see this was not good or a healthy situation. So what was the justification in our thinking why we needed to go into system changes? Firstly, we thought we needed to improve performance of the sector. And of course, we could measure performance in line with the MDGs. You could see all the MDG indicators were way out of what is expected to happen. But we also noticed that there was a shift in the epidemiological profile in terms of disease pattern, and we felt that health systems should be aligned to meet the needs, but also to make sure that delivery of public health services is in line with the government policy. So which are the areas which we felt we needed to put in some changes? As we are talking of systems, so you only don't change one issue. We thought we needed to look at the policy, and also that could be an area for change. But also we wanted to look at the inputs that we put in for health delivery. We also thought there we needed a change. But also we looked at the operations itself. How were we doing or conducting business? And we felt that also needed a change. Let alone on the outputs or the impacts, we needed to agree and think through what exactly should we be producing out of our services and how were we going to count. So we decided to come up with a framework for the change. So in 2004, government decided to adopt a sector-wide approach, the famous SWAP, as a framework for planning, managing, as well as financing health service delivery. We also felt that we needed to have a comprehensive sector plan in which everybody else would put in their voice, that is the nationals, the development partners, the NGOs and civil society, so that all of us would feel that this is our plan which we needed to implement. But looking at the disease profile, we also felt that it was necessary to design an essential health package that would deal with the issues or the diseases that were contributing to most of the morbidity and mortality patterns in the country. And then lastly, like I said, in one of our reasons was to align delivery of health services with public policy. At that time, government had just put through a local government act that empowered the district assemblies to be responsible for delivery of public health services. So as a health sector, we also decentralized delivery of health services to the district assemblies. So I just wanted to show you what the health sector plan is all about in Malawi. Firstly, the core business is to deliver the essential health package. But you can't do that in a vacuum. You need infrastructure so that you are able to do your business in. But also there's need for governance in terms of financing and stewardship for the health sector. We also felt that you cannot deliver health services without human resources, so that was also a target area for intervention. We also thought we needed to support the districts, even though central government, as Minister of Health, it wasn't our business anymore to deliver health services, but we thought we had a responsibility as the steward to make sure that the districts are capable to deliver health services in a better manner. But also the supply chain, if you don't have medicines, you don't have health services. So that was also a target area for intervention. And then lastly, but not least, we also need the equipment. You may have a well-trained physician, an obstetrician, a midwife, but if they don't have the things to use, then they will not be any good to the nation. So firstly, what are the areas that we felt we needed to change? Firstly was we wanted to make sure that we have a package of services that is responding to the disease pattern in the country. So the first area we looked in was how should we deliver health services? And we agreed that if for us to make the most impact, we need to go into an integrated manner. But what are the areas that we needed to focus on? We first of all thought that we needed to make sure that we have a good immunization program to prevent all diseases that we can manage. And then malaria, we all know malaria is so a killer in most of our countries. That was also our issue. Maternal and newborn health, which is the focus of this meeting, but also including family planning, that was also our major focus. Issues of tuberculosis, HIV, acute respiratory infections, those were also problems in the country. Neglected tropical diseases, we felt that if we continue to neglect them, one day it will be a tragedy, so we included them in our list. Non-communicable diseases, they're also coming up, as the literature says, and we felt we needed to look at them as well. Issues of nutrition, we saw pictures here of stunted children. Malawi is not an exception, so we thought we needed to include that. Issues of trauma, common injuries, eye infections, skin diseases, and diarrheal diseases. So in a nutshell, that's what the essential package for Malawi looks like, and what it also looked like in 2004. So we felt that if as a country we concentrated on this, we should be able to impact on our indicators. Now looking at the newborn and maternal health, like you noted that MNH is one of the essential health services. Now nested within the EHP are issues of maternal neonatal health, but we felt that we also needed to include other interventions that would make sure that the services are available. And this is use of service level agreement, which is like a PP arrangement with the non-public health players so that government can use them to provide health services and then to strengthen the referral system at community level. Now, I just need to remind you what the components of the MNH is, which was expounded on the first day by the Secretary for Health for issues of pre-pregnancy care and also focusing on the youth because we know they contribute to most of the poor indicators. Pregnancy care during the pregnancy itself, intrapartum care, issues of CMOC and BMOC in our facilities, and also postnatal care services. So I need not go into detail because this we have discussed since we came here on Monday. Now, strategy number 2, which also we felt needed some change, was to look at the human resources for health. You recall on my first slide, at that time we had 65% vacancy rate. So you'd find a facility that probably was manned by just one midwife or one medical assistant. So as a government, we thought we needed to do some drastic changes. So the drastic measures that we took in the system was, first of all, we mobilized the resources and gave them to the training institutions. I think we have people from the schools here. The principal for the College of Nursing is here. We have some colleagues from the College of Medicine. We gave these people money to improve the infrastructure so that they can increase their intake to 100 or 150%. This also included other schools, like the schools that are run by the faith-based organizations and those that are like semi-government institutions. We didn't stop there. We felt that if we only built the classrooms, the resource centers, but if the students are not able to pay, they will not come to the schools. So we went ahead and opted to pay school fees for these students, except for the students that were going to the university, because their monies come from Ministry of Education. But as for Ministry of Health, we paid for all the students that were going to the other schools. But we also felt we needed to introduce other cadres in the system. We introduced community midwives. We also increased the community health workers. I think Malawi is one of those countries that have salaried community health workers. Then we also felt we needed to delink the health workers from the main public service commission so that we can speed up their recruitment as well as promotion. So this is one of the flagship programs for Malawi in human resources. We also felt task shifting was the way to go because we didn't have enough physicians, enough midwives, so everybody task shifted to the lower level so that we can improve access. And we also took a drastic measure. We increased the salary of every health worker by 52%, and the community health workers got a 26% increase. And then we also supported the nurses and the midwives to prepare for their council examinations, because at one time we had a high failure rate at the board exam, so we felt we needed to support them. Strategy 3, to look at human resources, because if you can't measure what you are doing, then you are doing nothing. So we felt that we needed to improve the information system. So we integrated issues of maternal and newborn health into the national indicators for measuring the performance of the country. We have also put in notification for all births so that we know how we are progressing, and birth registration is now underway. We haven't had registration ever since the country came into being. This is a new issue. And also to use mobile health for easy capture of data. The supply chain, this was also one of the headaches. Episodes of stockhouse for essential medicines was the order of the day. So we felt that we needed to do something. And currently what we have done, which is of more importance, is to change the function of the central medical stores into a semi-independent institution so that it can do business as without interference from the government system. But we also have noticed that if we improve the supply system, we'll make sure that drugs that we need for the neonates and their mothers, they don't get out of the country as soon as possible. Strategy number 5, which I would probably take a little bit more time to explain, is we improved the financing system. This is the core business of the swap arrangement. At first, in 2004, we had a proliferation of so many projects in the system, with some projects doing very well, while the other part of the health system was actually in a miserable situation. So as a government, we took a painful decision that we want all development partners and government to put their money in one basket and finance the health sector strategic plan, which includes newborn health. But we noticed that there are some partners whose headquarters in New York, Berlin, and what have you, they were a little bit apprehensive, so we thought it would be a little bit flexible and allowed that if you cannot put your money together with the government, you can bring the money, but you will not implement what you think is good in New York. You will implement what is good in Malawi. So that's what we decided to do. And then we also decided to develop a tool for resource tracking. to see how much money is in the system. You'd be surprised what you can learn from this mapping. We notice there's loss and loss of money in the system, but the health budget is still very small, simply because the money is in the pockets of the partners. Yeah? And what we notice that is that the money is only supporting program delivery, not health system strengthening. So government has to struggle to train the health workers, to build the primary health centers, to buy the ambulances for supervision, while we as partners are doing the short-term trainings, this and that. So that's what resource tracking can tell us. So through resource mapping, we can sit around the table and negotiate to say, gentlemen and ladies, what are we doing about this? Let's put the money where we think it will produce some results. So we encourage DPs to support existing national plan, either at national level or at district level. So that we don't want to compromise. But we have also learned lessons from our colleagues in areas of result-based financing, and we are trying, and our first pilot is on MNH, not other things. But most of you know that government of Malawi provides free care. You can walk into any facility and receive care without popping a penny, despite whether you have come in a Mercedes-Benz outside, we'll give you free care. So government is saying, I think we need to do business differently. So we have now prepared a strategic plan for other forms of financing, because we noted that the treasury is running dry. Improving access, I've already mentioned about issues of quality assurance. If you don't have quality measures, you will not produce your things, but also to make sure that primary health facilities are within reach of the population. So we are building primary health centers, sometimes renovating them so that they can provide BMOC services, as well as standardization of equipment to make sure that they can be easily maintained and they can be procured without problems. Yeah, and just to show you that when we are saying we are building, we are not joking. This is one of our latest district hospitals to improve referral care. Leadership and governance, I noticed that I don't have any more time, but just to reassure you that we have created mechanisms for the partners to sit with government together so that we can discuss our areas of concern and come to consensus. I guess that's why government created a position of a director of SWAP. So my business is to make sure that the partners have a home where they can come issue their concerns so that we work like brothers and sisters. And we have a financing agreement that tells what government is, what its obligations are, and what are the obligations of the partners. And if we don't meet our obligations, we sit and decide how to move forward. Achievements quickly, we have improved the vacancy rates. At least when we had gotten to the end of our human resource program, at least we had addressed some of the shortages. I'm not saying we don't have problems anymore, but at least we have moved an inch. In terms of per capita spending on health, it is fluctuating, but we are in the right direction. Government is so committed to Abuja. Facilities now that are able to deliver a full package of the EHP, we are now at about 70. The same with the facilities that are meeting our staffing norms. We are moving in the right direction. Some of the improvements, the indicators you noticed during the first day, they have also improved. Challenges, some DPs still prefer projects. And we know that projects create islands of excellence in the midst of misery, and we don't want the misery to continue. Yeah? I've already mentioned that partners also like to finance program delivery, and that's, they don't look at the systems. If you don't have a system that is functioning, you will not get anywhere. So when you are planning in New York, in Berlin, where else, please look at systems as well, because you will not proceed if the systems are not functioning. The health sector in Malawi is expanding. A lot of private players are coming, but they don't like human resource development. So government is training and training, but the people are going to other places. So we want the private sector to also take part in training. Funding is still a problem, and of course geographical access is a problem. There are opportunities in the system. Political will is there. The president is on top of things. in relation to maternal and child health. Governance structures, everything is above board, everything is transparent, and the commitment to finding other ways of financing. Thank you, ladies and gentlemen.